We are very pleased today to have Dr. Stephen Crouch, Amanda Bowman, Diane Reedy, Dr. Sweta Singh, and Eileen Sullivan on this panel today. Steve received his medical degree from the University of Tennessee Health Science Center and completed his residency in emergency medicine at Carolinas Medical Center and is the medical director for integrated care management at Advocate Health, Midwest, Illinois. Amanda holds a bachelor's and master's degree in social work. She has over 24 years of diverse experience in clinical settings. She currently serves as the system educator of case management at Memorial Hermann Health System. Diane Reedy earned a master's in health administration from Tulane, a master's in nursing critical care from Emory, and a Bachelor of Science in nursing from the University of Texas. She also has a diploma in nursing. Reedy is the Senior Director, Care Management at Our Lady of the Lake Regional Medical Center. Dr. Singh completed her medical education from All India Institute of Medical Sciences and her postdoctoral research fellowship at the University of Michigan Medical School in Hepatology. She completed her internal medicine residency at the University of Arkansas for Medical Sciences. Her current role is the Medical Director of Care Management at the University of Michigan Health System. Eileen Sullivan received her Master of Science in Nursing Health Administration. Her undergraduate Bachelor of Science in Nursing is from Rutgers University. She currently oversees denial management at Atlantic Health System. Eileen is a founding board member of the American Case Management Association New Jersey chapter, where she served as secretary and president and currently is the past president. Join me in welcoming them. So I'm just going to give you a little bit of background information. As you know, this is our session, Learning Link Live, Answers to Case Management Issues. And again, we are delighted today to not only have our audience here that is live, I welcome you all, but I also want to welcome those in the future that are going to be listening to this via the podcast. Our abstract, you've all probably had a chance to look this over, but basically just want to mention this is, as I've said earlier, a really unique opportunity where we're going to be able to have this interactive discussion, interdisciplinary, with the panelists representing our Learning Link community. Let me just quickly go over the learning objectives. Today, we want to discuss key case management questions related to your practice. And as I mentioned maybe just a few minutes ago, in order to have this interactive session, we had these questions were actually submitted by persons through Learning Link. So that's where they came from. Next, our panelists are going to be able to identify options and answers to some of these questions, these practice-related questions that were posed. And the interactive live and remote, I've described how that will happen. We'll have our panelists do this, and then as well, you'll be able to listen to it afterwards. The third part, we're hoping we'll be able to examine some of the trends, and you'll see this in a minute because we have different categories of those questions. So hopefully we'll be hitting on the hot topics that are gleaned from this. And we'll say this towards the end of the session as well. Per chance, if we do not hit on every topic you're interested in, this is just the first step. So what we have is live Learning Link out there, or Learning Link, that you will be able to use in the future, even after this session, to post your questions and get answers. So just a few announcements. I mentioned that the Learning Link posts that were submitted before the session really are framing this panel discussion. Second, Learning Link posts are open for you. And again, we have handout information or on-site representative. We have a person here from ACMA that can help you with sitting in the back. Liz is in the back if anybody has questions about how to use Learning Link. But you certainly can post even after this session. We want to keep this dialogue alive. As I mentioned already, the session is being recorded and you're welcome to listen to it as a podcast. So those are the announcements. What we did is we looked at what are the most common questions. And these are some of the categories we pulled together, again, evidenced by the questions that were posted over the past few weeks. Kind of fell into three general areas: care coordination in transitions, UR regulatory, bundled that all together, and things that pertain to models, resources, outcomes. So within those three groups, you will see that we'll be having questions that relate to them. I mentioned their names in the bio, but just wanted to point out that these are our panelists here. And if you briefly just want to mention your name so you can identify who is who up here on the panel.
Steve Crouch.
Amanda Bullman.
Sweta Singh.
Eileen Sullivan.
Diane Reedy.
Thank you, panelists. You'll be hearing more from them. So I'm going to hand this off to our moderator, who is Dr. Crouch, in a minute, but I just want to summarize again what brought us to this point. You've met our panelist and our moderator, and they will be speaking about these questions or these posts that were of interest to you all. So basically, what we're hearing about are some of the questions and challenges that are out there. Our goal here is for you to hear of some of the ideas, answers, and solutions. Lastly, at the very end of this, hopefully you'll be able to have some key takeaways and new ideas. So that's what we hope to achieve. Thank you for joining us this evening. And I'm going to hand it off now to Dr. Crouch, who will be starting us off with some of the Q&A. Thank you.
Thank you, Sandy. So we're going to get started. We've got probably 9 or 10 questions to go through. If we do have time at the end, we'll certainly open up the mic if there's other questions or areas you would like to explore. So the first batch of questions are under the care coordination transitions bucket that we've identified. So the first question is, do nursing and care managers rely too heavily on therapy and their evaluations to determine the discharge disposition for patients? So, Amanda, I'm going to ask you to answer that question, please.
Yeah, thank you for that. I think that there's a lot of debate on next site of care being documented within the therapy's notes, especially with the age of technology. Patients that have access to their chart at bedside, they're on their cell phone and they can see if physical therapy is recommending inpatient rehab facility as opposed to a skilled nursing facility, when you know that the insurance that the patient has is not going to cover. And in IRF, you know there's going to be a long battle of appeals and denials that come along with that. So making sure that physical therapy and occupational therapy are not having those sidebar discussions with the patients, and also not presenting the documentation in the medical record that could be conflicted with where the patient actually discharges to.
Thank you, Amanda. Does anybody else on the panel have anything to add?
This is Sweta here. I want to also add, I think the nursing and the case managers, they are relying on physical therapy for their expertise on next level of care for the rehab part, but they can sometimes still evaluate and a lot of times know before the physical therapy puts in their recommendation what are the chances patients would need a subacute rehab from just the medical complexity or skilled nursing needs, and prepping that ahead of time can be very helpful for early identification so they can ensure that provider puts in a timely physical therapy orders. As a hospitalist, I think that's one thing we do rely heavily on our case managers saying, hey, this patient doesn't have a PT note, so won't be able to get an insurance authorization, and you clearly see the skilled needs. So I think they do rely on their notes for insurance authorization and recommendation and collaboration, but case managers are at a very advantageous position that we can look at the holistic picture and look at the insurance, look at the other things that patient needs.
Great. Thank you both for those answers. The next question is, are nurses getting patients up to ambulate, and/or what ideas can you share that help progress patient mobility during their hospitalization? I'm going to start with Sweta.
Thank you for this question. When it was posted, I was excited, especially because we have recently done few new pilots in our hospital. How many times we've run into a scenario where patient comes in for heart failure, was pretty independent at home, but 5 days, 6 days into their hospital stay, when we've all arranged for home care and home post-discharge, and they are now failed PT, need skilled subacute rehab facility for their discharge for rehab purposes so many times just because patient didn't get out of the bed. So we had an initial pilot where we had kinesiology students work with the patients on regularly getting them out of the bed first day into their admission, not even waiting for them, at least offering them help and making sure that they get out of the bed, preferably 3 times a day. And they had great success with the JHM, the mobility scores. So we extended that into the units and have nurses and techs regularly get the patients out, track the JHM mobility scores, and have good success stories where patients who were initially recommended subacute rehab were later actually recommended for inpatient rehab because they've progressed so well. So in terms of what we can do, we are asking our nurse case managers to go in and check every other day the mobility scores of the patient along with the unit managers and the other set of eyes to see if their scores are going down. It's a time maybe nurses need to push the patient more. Sometimes it's patients are not now, and we are too busy to come back because we have other patients to take care of. But these little small things can be better visualized when you're looking from a step back and at a bigger picture. So that has been pretty helpful in our system.
Amanda, I think you'd like to comment?
Yes, thank you. I think a lot of times it has to do with nursing leadership and the comfort level of the nursing staff on getting some of these patients up and out of the bed prior to physical therapy, doing their initial evaluation. I think we can all agree, just even if we have a loved one that's been in the hospital, we all know, hey, my dad, he's independent. You can get him up. He just needs to give him a little kickstart. You got it. Get him a little motivation even. This isn't a lack of his ability. Just, tell him he can't just lay around in the bed. And we've, had encounters where the nurses are like, no, we're going to have to wait on physical therapy. So really getting with nursing leadership and being partners with them, because we all know as case managers, the sooner the patient is up and out of that bed, the sooner they're going to be able to go home. And the longer they are in the bed, the more chance, like Sveta said, is that they're going to need some sort of post-acute services for therapy afterwards.
Thank you both on that. So the next question, again, still under the care coordination transitions bucket, is we are having an internal discussion and I'm seeking input regarding post-acute referrals to providers within our system. Do you give preferential treatment such as advance notice of referral, right of first denial, or post-acute provider referrals in your system? Again, Amanda, throwing it to you.
Thank you. You may have skipped a question, but that's okay.
I did. We'll go back.
So I promise I'm not going to hog the microphone the whole night. So we actually do have an aligned network that we work with very closely with Memorial Hermann. They have to meet very specific criteria. One of the things that we've worked with our referral partners is to make sure that when we provide a list to the patient or to the family, that it's highlighted, it's different, it looks different, it has the very top part's all yellow and highlighted for those. And it's also important, we've done a lot of education with our case managers across the whole entire system to make sure that they understand what patient choice actually is. Because yes, you have to go in and have this discussion, but it's an informed discussion of patient choice. So if you know that the facility that they're wanting to go to does not meet the ability to be able to provide the level of care that the patient's going to need, you're the expert in this field. You have an obligation to have that discussion with the patient and the family. So whenever we go in, we always talk about preferences. Have you ever been to a skilled nursing facility before? And if you have, would you like to go back to that facility? I can send and make contact with them. But also, here's our Align network. These post-acute providers have been gone through lots of different avenues to be actually part of our network, and I'd like to connect with them as well. So that way there's not a delay with you being able to get to your next site of care to get you home faster. So making sure that, yes, you and Medicare and CMS are very clear that you can actually give your list of your Align network. You just cannot refuse to also do their preferred and their requested. So it's making sure that everyone is all on the same page.
Thank you. So the next question is, are organizations collaborating with payers to improve turnaround times for post-discharge needs such as subacute rehab, LTAC, other post-discharge needs, and those authorizations? Diane, I think you're going to start this answer.
Thanks, Steve. We are working with payers to collaborate because right now, at times, we're caught in the middle between the post-acute provider and the insurance company, each one of them being very adamant that they are doing everything they can to help our patient discharge. But we're still waiting to hear from somebody. Did you get the authorization? Has the patient been approved? So we have had insurance companies willing to work with us to allow the case manager at the acute facility, once we have gotten a post-acute facility to accept the patient, to send in the information so that then we will know how long it's taking the insurance company to approve that patient. And then we will turn to the post-acute provider and say, you have auth. Come and get the patient. And there won't be that constant, he said, she said, where's the auth? How long are we waiting for it? Did you submit it? And also, we are in the best position. If that insurance company needs more information about the patient, we have all of it. And we can easily get additional information to the insurance company very quickly because we want to move the patient. We want that patient to go to a post-acute facility. So our payer partners, that's what we're trying to do, build that collaboration so that we have an easier discharge.
And I know that in my organization, we're also trying to collaborate with some of the payer partners and actually asking them what we're not doing well that would help them turn their authorizations around quickly. Like, is it we're sending information too soon? Like if we waited, later in the day to send them updated stuff, or they're not getting the physical therapy note that they need. But we know they're going to need it, but we know the patient's going to need a post-acute, subacute rehab, and we're going ahead and asking for that off, but maybe we're not including the right clinical information that we need. So that's something we've been doing as well. Anything else from anyone else on the panel? Okay. The last question in the care coordination transition bucket is for those without electronic referrals who still need to print that referral and then fax that information in. After entering the notes in the EHR, do we also need to then print and scan these documents, referring back to those ones that they had to print and then fax in, and scan those into the EHR, or can we shred them? Diane, I believe you're going to answer that.
Well, you've just printed all this out of the electronic health record, so you don't need to keep that. But your note needs to reflect that you did the progress note by physician, name, date. If you don't have a way of recording that electronically in your system, then you need to record that the note was very specific. Dr. Smith, April the 3rd, 8 a.m., that's the progress note you sent. So if there's no way to record that in your system, then you need to just be very specific in your note as to what documents you sent, but you don't need to keep them because those documents are already in the record. For those of you who have Epic, you will automatically keep something in the medical record of what you sent to that post-acute provider because you're able to send those documents and it records it in Epic. But for those who don't, you can shred that document as long as your note is specific. And that way you'll be able to go back and refer to the exact information that you sent to either the insurance company or the post-acute provider. So shred away.
Thank you, Diane. So we're going to transition now to the UM/UR regulatory bucket. And again, we have several questions under that bucket. So the first one is, how are organizations holding Medicare Advantage plans accountable to follow the 2 midnight rule when they review admissions for appropriateness of inpatient or Part A payment? Eileen, I think you're going to kick us off there.
Sure. So I'm finding that Medicare Advantage plans, many of them don't understand the 2 midnight rule, still having trouble with it. Think it starts after 2 midnights when it actually, if the patient is not going home after the first midnight, we know they're staying a second midnight for medically necessary care. That inpatient decision should be made then. So the first thing you want to do is make sure your patient is meeting medical necessity for that second midnight. They're not staying for care that could be safely provided in the outpatient setting. So once you've established that medical necessity has been met, utilize your peer-to-peer process. If they're denying it, saying it should be observation, and they had this Medicare Advantage patient had 2 medically necessary midnights, utilize the peer-to-peer process and monitor it. I have one hospital where they have 20% of their denials have a peer-to-peer. And we're setting a goal that as close to 100% of the denials should have a peer-to-peer, because 80% of peer-to-peers are successfully overturned. So it's really important to utilize the peer-to-peer process and hold people accountable for when that's not being done. The second second recommendation I would have is if you appeal this 2 midnight denial and it's upheld, utilize the CMS provider complaint process. CMS did simplify that last June in 2024. The American Hospital Association put out a great tool to how it's a 1.5-page form. You fill it out. You have to encrypt it. That was a little hard the first time I did it. But you get a response and it sort of shakes the payers up. They'll think twice before denying a necessary 2 midnight stay again. If anyone doesn't have access to this American Hospital Association presentation, you can just ask on Learning Link. That's one of the great things about Learning Link. You just ask, and in about 30 minutes, you're going to get shared PowerPoints and sites that you can use and links. So if you wanted to say reach out to me, you could even send me a message. You just know my name. You can just find me in Learning Link and send me an email. People they're very willing to share things. And then the third recommendation I have is to reach out to your managed care contracting. When you appeal with the payer and your contract says that the internal appeal with the payer is the final say, there's really no incentive for them to overturn that denial. So we have tried to get in a lot of our contracts that we have the right to go to an external third-party quality improvement organization to review. And then the other piece of that I like is the 3-physician panel, which is very similar. We take some of our, high dollar, so that we don't want to go through an appeal process and pay our vendor 20% to get it overturned. We have a 3-physician panel. We set it up. One of our physician advisors, the payer's medical director, and then a physician from the independent QIO. It's a 3-physician panel. And, we usually win. We really don't send cases to the 3-physician panel unless we're pretty sure we're going to win, and the loser pays the QIO. So it's a really great way to hold these Medicare Advantage plans accountable to midnight rule.
Great, thank you, Eileen. So, I'm going to add a few things. I agree with everything that Eileen said. Our organization, when 4201F first came out, we decided that we were going to meet with our the senior medical directors of the 3 or 4 MA plan, the largest MA plans that we had to deal with, to understand how they were going to educate and standardize their approach. Because part of the approach to the 2 midnight rule is, they should be creating something that's objective and not necessarily subjective. So we met with a bunch of the, like I said, 3 or 4 of the MA plans to understand, so that come January 1st of last year, we kind of knew what to expect. And if we weren't going to, if our experience was started to be different, we could go back to the senior medical director and say, well, wait, you guys said you were going to do X, Y, and Z. So, for example, one of our payer partners said, if it meets MCG, coming no matter when or how long they've been here, they're going to approve inpatient. Another payer partner said, well, it's got to meet MCG at some point, whether it's here for 2 midnights or not. They're using MCG kind of as to make sure that they're being objective and they have inter-rater reliability. We could always discuss whether that's the appropriate interpretation of the 2 midnight rule, but at least they provided us with what we could expect. And if someone was varying from that, we could always go back to the senior medical director and say, okay, well, your medical directors aren't doing what you said. Did something change? The other thing, we have done is we do have a pretty good relationship with our payer partners. And actually one of our MA payer partners came to us and said, hey, we noticed that we're overturning a lot of these after the peer-to-peer. What do you think? So they came to us and said, what do you think we could be doing better so that we don't even have to waste everybody's time doing a peer-to-peer, because we're getting we're end up turning them over. As most everybody knows, most reasons for denial is that they just have insufficient medical records or something changed, like they looked at it quickly and then they had that stress test or that cath and now they're going for a cabbage. So, again, however your organization may have, or they may have access to your medical records, helping them get access to the right clinical information, whether that's again granting them access or making sure you're sending the right clinical information. We also ask them, well, instead of so quickly denying it, can you wait a day until things kind of get more clarity? Because we're calling you the next day and then you're overturning it because there's already a day in between there. So that's kind of what we did up front. What we've done on the back end is some of the stuff that Eileen has said. We are, on the front end when we're doing second level reviews, unless there's, really nothing going on or it's, an avoidable day or delay. We're flipping everything as it approaches the second midnight, because that's the way the 2 midnight rule is supposed to work. And so we're doing that. We're taking those cases to peer-to-peer. We're a year and quarter into this, and we realize that there are certain scenarios that the payers just are never going to say this met the 2 midnight benchmark and we're going to approve it. A prime example of that is the older patient who comes in with a UTI that's a little confused. The next day they're completely better. We're keeping them the second midnight on IV Rocephin just because we don't know what the culture is going to be. They've never had a UTI in the past. I think if some of those people showed up at their doctor's office or immediate care, they'd probably get sent home with PO antibiotics and somebody would follow up with the culture. So some of those things we know that they're not going to overturn. So we've stopped taking those to a peer-to-peer because we're just trying to make our lives more efficient. But anything else we're taking to a peer-to-peer. If it's not getting overturned, we're going through however many level of appeals. Some payers have 1, some have 2. Because if we ever Then if we are going to submit a complaint to CMS, or you're going to go back to contracting, if any of those other points you acquiesced and just gave in, the payer's just going to come back and say, well, you didn't think it was really an inpatient because you didn't appeal it. So you do still have to go through those steps. My experience with the complaints is we submitted some of those kind of late in the game. You know, people have always asked, you know, is CMS really doing anything about the complaints? I think they are, because with that new proposed rule, and I can't remember the number, that they came out with in the fall that was supposed to be enacted sometime this spring, adding a little more teeth to the interpretation of the 2-midnight rule and the MA plans. I think that is based on the feedback that they've gotten from providers and about how some of the payers may not be interpreting the 2-midnight rule either consistently or the way it's intended. When I started submitting complaints, I quickly got back answers was just like, you know, yes, we've heard your complaint, but, and because what I got back from the payer was not satisfactory to me. So then I sent it back to CMS, and CMS just basically came back and said, because of, and again, I can't remember, it was like 40 something, can't remember the number, but they said, you know, we've proposed this new rule. We think that's going to address that. So we stopped sending complaints until this new rule gets finalized. Don't know whether that's ever going to happen with what's going on in Washington, D.C. right now, because I think that's just going to be the answer we're going to get back from CMS. So we'll see. And again, the plan is, if that rule does get finalized, is to meet with our payer partners, find out how they're going to interpret it. I mean, we've had a lot of dialogue with the frontline medical directors about how they're interpreting and how, we think it should be interpreted. And so it can be a very collaborative back and forth conversation. And sometimes you just have to, agree to disagree. So that's kind of what we've been doing. And again, going to contracting, as well, that's kind of like the last step. I mean, we've thought about, asking, let's send some cases to the QIO and see how that interpret it so that we can see who's right and who's wrong. But we have not done that yet. But I don't know, Sweta, do you have anything else to add?
No, I think you summarized it pretty well, and we haven't filed CMS complaint yet, primarily because every time we run into similar situation, we've been able to engage our contracting and the peer medical director, and a lot of times if the medical director who did the peer-to-peer may argue saying, oh, medical necessity not met because of criteria not met, we've been able to reason it out with their leadership and say, hey, this case definitely merits, and it's a 2-midnight and is medical necessity with enough intensity of services, and criteria should not be just the guiding principle, and they've been able to overturn with that escalation. But yeah, we have in our contract or where we have that opportunity to escalate it, not just to the level of appeals, but after the appeal level, we have quarterly meetings, sometimes with different peers, with their leadership to discuss these challenging cases.
Okay, great, thank you. So we're going to move on to the next question. We review Medicare patients within 24 hours of admission, but we are having a high number of code 44s. We want to change the process and perform reviews prior to the admission order or OBS order and include UR status recommendations, but want to be sure we are being compliant with CMS guidelines. Our UR is outsourced, and the company raised potential compliance concerns if it would be perceived that we are influencing the physician's decision on status. Can you share your ideas or experience with this approach? Sweta?
That's a very good question, and something we struggled to a few years ago, where we had a pretty high code 44 or write-off rates, primarily because we are in a big academic medical center where providers do not completely understand the patient status, and they think if the patient's coming into the main hospital, everyone's inpatient, and would admit everyone as an inpatient. That was not only for Medicare patients, that's a challenge also for commercial patients, because then you're having a high denial rate. And they are gonna first then default to, okay, they sent too many inpatient claims, we will deny, and then see what they file back as try doing peer-to-peer, and then consider inpatient and have approved before peer-to-peer. So what we did at our institution, one, it is okay, it is compliant to have an initial review on admission. We have ED URRNs, we have had that for several years. All our admissions, when getting admitted, they get reviewed by the utilization review nurses, the first level review, and they run the interqual. We use the interqual in our system, and again, every system can have a different criteria, and put in a recommendation in our EMR. So once they put in, puts in the field, fills in the field, okay, patient met inpatient criteria or not, or observation level of care met. So when the provider is putting in an admission order, our ED has admitting privileges. When they put in a step 2 admission order, they can see what was the recommendation. How many times do we have providers follow that? Well, some of us who are in the UR world would look at it closely, but most of the people would just blow through that BPA or those pop-ups and still do what they are used to doing. It didn't help us too far. So we had to have a hard stop. Again, it's a recommendation, and hard stop is saying this is a suggested recommendation based on criteria, which is filled on the current information, and that here is a pager or contact number to reach out to if you disagree, and we can discuss. And that way, we've had a lot more compliance from the provider, and in terms of having a consistent order between the ED provider as well as the admitting team. Because a lot of times, what we would run in is an inconsistent order, because admitting team would be like, yeah, agree with observation, but the ED provider put in an admit to inpatient. This helped us not only reduce down our code 44 rates down to 1 or 2 a month that we have to do, but also helps with patient satisfaction too, because now they are getting notified early on. 2, that helped us with our denial rates with the commercial payers, because they are getting appropriately patients who should be inpatient. And we are still reviewing all these cases. Yes, it did have a downside where we had more observation initially. We had to have more rampant UR inpatient, UR nurses review. Again, we review all our ops cases pretty closely and have them escalated to physician advisor, and more opportunity for provider to physician advisor communication and education. And again, goal is not to dictate or provide influence the status. It is to educate, as code 44 is meant to be a rare occasion. That, oh, it's a learning opportunity. We put the status. It's not okay to have a lot of code 44. Let's just start with inpatient and see if it would fly through, and oops, not, let's go to code 44. So I think it would be more compliant if we are being consistent in our messaging, providing the patient with the real information, moon notices on time. We are providing them with their absolute accurate status, and then helping them through the process.
Thank you, Sweta. Eileen, I think you've got a few more comments.
Yeah, I just would like to add that I think the outsource company is not accurate, that, it's very important to utilize the ED UR nurse to recommend a status, and Epic has a great field that will help the admitting. We have ED admitting hospitalists right there in the ED, and they look for that. The only thing I would add is that your ED UR nurse really needs to be sharp. She needs to know utilization review. She needs to know observation. He or she needs to be able to articulate what documentation is needed to support 2 midnights, or what observation is. They should be able to pass, your criteria tool into rater reliability. A lot of times I've seen, per diems cover the ED, or, case managers that are really better suited for discharge planning. So I just can't reiterate enough that your ED UR nurse needs to be a sharp UR person.
Great, thank you both. So this next question is around CMS guidelines and expedited referral process. So CMS information is not totally clear on the expedited referral process. Can you share your insight regarding days in the hospital for Part A and Part B groups and the eligibility for the expedited referral process? Eileen?
Yeah, so this question is about the new Medicare change in status notice, probably the most confusing thing CMS has done to us in a while. And it's been made more confusing because Levanta is saying something different from CMS. So the best information that I got, I went to a lot of in-services, and we even at ACMA New Jersey chapter did a great in-service as well. But if the patient has Medicare A only, you deliver the Medicare change in status notice as soon as they're converted from inpatient to outpatient with observation. If you're just doing a code 44 and they're going, the patient doesn't get the form. A lot of people think code 44 takes the patient back to observation, and it doesn't. It takes them back to an outpatient, and observation should be ordered going forward if the patient requires observation. So again, if they have A only, you deliver the Medicare change in status as soon as they're converted from inpatient to outpatient with obs. If they have A and B, you deliver it 3 days after 3 days have passed since the original inpatient order, so before the code 44. But I have submitted questions to Levanta and CMS to clarify their guidance because it conflicts. So I'll post that on Levanta, but it's very, very confusing, and a lot of hospitals really are not even doing them. And Medicare has said they should be rare, because if the patient is converted to outpatient via the code 44 and they're going home, they don't need to get the form. And if you're going to order observation, they likely meet the 2 midnight rule. So they should be rare.
Okay, thank you, Eileen. I agree with you. It was very confusing and still is very confusing. Fortunately, I don't think our system has even had to do one of these yet, but I'm sure we'll struggle with that as long as everybody else. Do you have a question? Do you have a comment, Amanda?
I do. We actually have had to do quite a few since it's gone live, and obviously they're rare and unusual, and you would hope it'd be a unique situation. But apparently, we have quite a bit of a population of patients that don't have Part B. They only have the Part A. And then for some strange reason, we have a lot of patients that have been staying in observation status or have been in the hospital for the 3 days. And the way that we built the work queue out within Epic is 3 days from the time that the patient hits the hospital doors, including ED time, just because there was not enough information, and CMS didn't know. Even whenever the patients would call to actually do the appeal, Accenture had no idea what to even tell them. Whenever the case manager directors would be calling Accenture, hey, how does this appeal even work? They wouldn't know. They didn't even have any idea what an MCSN was. So there's a lot of confusion out there still regarding the form.
Great, thank you. So the last question in this bucket is, we are a critical access hospital and sometimes need to send observation patients to one of our sister facilities about an hour away for procedures such as a renal stent placement. I'm told we can do this for inpatients, but not for observation patients. Can you lend any insight onto this topic? And I'll start with Diane.
Thanks. You have to remember, this is your patient going somewhere. So wherever the patient goes, they're still your patient. And you are responsible for that patient and also paying that other facility. If it's in your system, that makes it easier. But if it's not within your system, then you need to make sure that that payment is done appropriately. And with observation, you also have to be sure how you count the hours. In some EHRs, the hours are counted automatically for you, so that saves a lot of time. Eileen?
So I would just add to that Epic does have a leave of absence order. So we have, when we ever have a patient that has to leave for a test somewhere at another, if someone had to go to have a dental procedure. So you would have an order in for the leave of absence, and then that's reconciled when they come back, and just make sure that you have a leave of absence policy as well.
So That ends that bucket of questions. We're going to move on to the models, resources, and outcomes. We only have 2 questions here. The first one is, does anyone have ideas for template information to use during interdisciplinary rounds to help improve workflow and decrease length of stay? Sweta?
That's a good question. And we do have, again, this can be a little bit lengthy, so feel free to message if you need more details. But to simplify, we do have what we call the multidisciplinary round, interdisciplinary rounds have to be targeted to the audience. What that means is 10 seconds for provider to give a brief clinical summary, but then share more in terms of what are the clinical needs, what is the anticipated discharge date, and what are the care needs. We also have clinical assistant, social worker join these rounds, so we have targeted information as to what these would look like. Having said that, there is still always variability as to who's running these rounds and how they would present. So template makes it super easy. Again, if you go online, IHI, Open School, there are multiple available templates that you can see, but you have to tailor it down to your university or your hospital or your program and see what would make most sense to you. So we do have in our EPIC system, in our EMR system, what we call discharge checklist. It's a one-stop shop where we have automatically pulled in information and some information that case manager puts in. It has buckets like care manager has what are the needs identified, what was the SDOH score, are there transportation needs, discharge plan, AVS, and we also have a category for nursing, so they can put in like patient education part that they need to do, or how to pick line or any IV access training or other training that the patient might need. Then we have a section for physical therapy, occupational therapy, so that it pulls in the most recent. When was the last note? So do we have a note within 48 hours? What was the last recommended disposition? And other care needs or pharmacy, as well as like waiting on prior authorization, things that can automatically be pulled in, don't need to be discussed. But what is the most active or the next step that we are in? So we focus on that, as well as if we identify any barriers. Again, I can share the template if you guys would like. Feel free to send me a direct message through the learning link. Amanda, do you want to add?
Yes, our health system actually started Epic in October, and it has a really great template in there already built out. For our health system, the nurses on the units are the ones that actually complete, type in everything. But it's also very intuitive. So it'll pull information that's already put into flow sheet documentation. So whenever the case manager's already documented in the discharge planning assessment, it'll pull that information. So, next slide, where the patient's going to discharge to, that type of thing, any barriers to the discharge, that's going to automatically be pulled in. The expected discharge date, we've made it very clear that everyone on the team owns that, and to make sure that it's as accurate as possible, especially for case management, because it does generate those CMS compliance forms to the work queue. So the copy of the IM, when that needs to be delivered, everything is generated based on that expected discharge date. So that is one of the things that, even though the nurse is the one that's actually documenting everything, it's the ultimate responsibility of the case manager to ensure that the expected discharge date is accurate.
So our last question, several of our panel members are going to provide their insight. Can you share effective strategies to justify and gain approval to adding staff to meet increased workload? Also, can you share new strategies to meet increasing workload other than or in addition to adding staff? Diane, would you like to start?
Thanks. we have always had some difficulties hiring registered nurses and social workers in our area. So we have come up with different strategies that worked at different times, always trying to focus on what the registered nurse and the social worker, where their skill set is and where we need to use them most effectively. The hardest part of the justification is tracking the data that you want to use to say our workload is increasing. So when you look at case mix index, sometimes that helps. Post-acute placement time, I find that that is also very effective because you have the time in your electronic medical record of how long it's taking you to find placement for a patient. It has also been very effective by our event monitoring system is tied to our medical record. So we want our staff to enter events into our event monitoring system. It's easy for us to track it that way. When we look at turnaround times, when we look at different surgeries, different procedures that the hospital has started, we recently started ACMA, those things have a bearing on the level of intensity that you are. We are also a level 1 trauma center, and those patients, when they come from all over the state, are very difficult to put back into their communities and to find a place for them. So we also track that. So it's particular to your hospital. What we try to work very hard to make sure that the social workers and the registered nurses are working at the top of their license, doing those things that only they can do. And we've hired some helpers to do some of the other things. Eileen?
So my recommendation regarding staffing strategies is to embrace AI. When we went from using artificial intelligence in our UR department, we went from having 20 UR nurses to 6. And at first, people were saying, this is an 800-bed hospital too. How am I have 80 people, 80 patients on my work queue, how can I do this? But when they were doing manual reviews, it was taking 15 to 20 minutes to do a review, and with AI, it went down from 1 to 2 minutes. We have case management assistants, sending the documents, just clicking on certain documents, sending it over to the payers, and the UR nurses challenging the denial. So they really weren't working every single patient. They were just making sure MedNec was met based on the AI score. They were disputing denials, setting up peer-to-peers, sending additional information. This meets. Then they would apply manual criteria if there was a denial. So they weren't doing this heavy lifting for every single patient because most patients do belong in the hospital. So that really helped out a lot. And so people were also afraid about layoffs, and I don't think case managers will ever be laid off. There's just so much need for them. We just repurposed them to where we need them. We have them in, we're always short for discharge planning, so people went back to discharge planning. Our patient satisfaction scores went up, our readmissions went down because we had more people and more emphasis on a safe discharge plan and a warm handoff to our transitions of care team.
Thank you, Eileen. This is Sweta. I would say we utilize a lot of similar strategies in our hospital. We have a clerical staff that helps case managers do take care of a lot of what we call them is case manager assistants, taking care of delivering notices, arranging for transport, finding the vendors, etc. And similarly, we have assistants who help with some of those clerical work of sending the faxes, following up, checking those boxes for the payers, and taking care of a lot of those things that don't need to be having an RN behind their name to be taken care of. Even for our peer-to-peer scheduling, so if a denial comes through and physician advisor thinks that this should be argued as a peer-to-peer or this needs to be appealed, then we have a clerical staff that works on scheduling that peer-to-peer with the provider and taking care of just being on hold for an hour with the payer providers to schedule those peer-to-peer. The other things we do use in terms of how to justify for our nursing, the nursing staff and social workers, SDOH, now that it adds the Z-scores adds to the complexity and the reimbursement for our patients, we've utilized that also to show the significance of our social worker and help bring some, because what C-suites always want to know is the ROI. And a lot of times, unfortunately, what they see case management department is a cost. So these things in terms of denial overturn, SDOH scores, and reducing readmissions or reducing these length of stay parameters, things that we can utilize to justify and make sure we have a safe patient to nurse ratio. The other things we utilize in terms of when we have a nurse case manager who has a very complex team, because we all know that cardiology team care needs would be different from orthopedics care team needs. So balancing out their distribution between, so they don't have two very busy services, but at the same time, we are able to maximize their expertise. Our pulmonary nurse case manager knows the vent arrangements in and out, knows the ordering and the insurance limitations in and out. So we utilize that to maximize the efficiency, have a backup plan for that subspecialty so that we have that good understanding and efficient workflows. I would definitely be interested in looking further into AI. That's something we haven't tapped into, but we do have our own internal builders, or our institution does have providers or care team members who are interested in creating the AI tools within the Epic system or within the Tableau system that pulls into the Epic. And we've been utilizing them to help improve our EMR system so that we can identify some of the cases early on, even with similar things like obstinate patient conversion, or what are the risks for some of these patients.
Thank you all very much.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so that you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.